Okay, so very good. We are now officially recording. So this is the Unit 5 exam review prep session, kind of last minute push before the exam. So I'm open to any and all questions. I will answer anything, provided exactly what is exactly all the tests and stuff. Don't ask me that, but I'm happy to clarify any type of content that you have. So if you just want to start putting them in the Zoom group chat, and I'll just kind of work my way down. Don't be afraid to ask questions. I will reiterate at the end, and I'm going to say it right now. If you have not yet done the little Google games to kind of really focus in on pharmacology, if you have not looked at the Jeopardy game that was created, or if you have not done the ATI practice test, you want to make sure you do that prior to the exam. They were developed to help you with the exam, so please do them. Okay. All right, so we'll go ahead and get started. Starting right from the top. Do we need to know principles of the anion gap? Not so much for this level. What I'm looking for you to be able to do from an ABG perspective is be able to look at the values, determine what type of acid-base imbalance you have, and if there is compensation, and if there is compensation, is it partial or is it full compensation? Okay. Anion gap is helpful in identifying metabolic conditions. You'll get more on that next semester with Mrs. Faust and Mrs. Hyatt. Our Unit 5 really focuses on the respiratory piece. Okay, so respiratory acidosis, respiratory alkalosis, and the compensation piece related to that. Okay, so very good questions. What is the best way to diagnose a DVT? Venography or venous duplex ultrasound? It would be venous duplex ultrasound because that is going to be the most invasive, or I'm sorry, let me rephrase that, the least invasive. That's the easiest one for them to do. Essentially, you're just doing an ultrasound of the legs. You're looking to visualize the vessels, and we're looking for clot formation within there. Okay, so your venous duplex ultrasound, that's what you're going to look at primarily for your DVT. The venography is much better if you're trying to diagnose like peripheral venous disease, looking for incompetent valves in the veins, that sort of thing. Just want to clarify something from the Google Classroom. Is enalapril really IV only? Yes. So enalapril, just ending with just the pril, that is Vasotec, and that can be given PO. The IV form of that is enalapril. Okay, so you have the enalapril and then the little it at the end. That is the IV form. So remember, when you would be using the IV form, it is in times of hypertensive crisis, hypertensive urgency, emergency. And at that point, we would want to use an IV medication because we want it to start working fairly quickly. Now, do remember, when we're treating your hypertensive crisis with your IV medication, we don't want to drop them significantly too quickly. So we're looking at a reduction in the systolic pressure about 25% in the first hour by using that IV medication. So enalapril, just with the straight pril, that's going to be your PO dosing. With the AT at the end, that's going to be your IV dosing. Okay. When a patient has peripheral artery disease, will the patient want to keep their legs in a dependent position? And when they have a venous issue, will they want to keep the legs slightly elevated? Great question. So let's start with peripheral arterial disease. So with the arterial disease, the problem is getting blood flow down to the toes. So they would want to have their legs in a dependent position. That's going to help, that gravity is going to help with that blood flow. However, that's going to create some discomfort, some pain with that as well, and especially with activity. So when we talk about somebody with peripheral arterial disease elevating their legs, they should never elevate them above heart level. Okay, never above heart level. And they don't want to keep their legs elevated for long periods of time because it can actually hinder circulation. Now, on the flip side, on the venous side, remember, those people have problems with venous return. So when they're in a dependent position, they're going to have pooling of blood, and that's where they're going to get really edematous. and really kind of puff out those vessels just because all the valves are incompetent. So your venous people, we do want to have their legs elevated, okay? But again, we generally don't want to go above the level of the heart. Can you go over the different corticosteroids? Yes. So when we talk about long-term corticosteroid therapy, that relates to maintenance therapy or long-term management of things like COPD and asthma. So when you're talking about long-term corticosteroid treatment for respiratory disorders, we're typically talking about inhaled corticosteroids, okay? That, you know, they're taking just as a maintenance medication. Now, with that inhaled piece, there's different ways they can be administered. It's all inhaled, but you can have it as a DPI or a dry powder inhaler. It could be a meter dose inhaler that they, you know, push and the spray comes out instead of the dry powder. Or these can be administered via nebulizer as well, things like budesonide. So either way, you're still talking inhalation. It's just different, slightly different forms of how the medication, you know, comes. Regardless, whether you're giving nebulizer, meter dose inhaler, or DPI, with your steroids, it is a critical point to make sure they are rinsing out their mouth, because otherwise they're going to develop thrush. So those are ones that we use for long-term therapy, okay, long-term maintenance therapy. For short-term exacerbation management, that's when you're going to see the IV methylprednisolone, or you'll see the PO prednisone used. Those are going to be more short-term because we're trying to get the patient over the hump of the exacerbation, okay? We're still sticking with the inhaled corticosteroids because that's part of their long-term management regimen, but we need a little bit extra kick to get them over this acute inflammation that they have with this acute exacerbation, okay? And it's with the IV and PO, more so the IV steroids, where you see the significant hyperglycemia, where their blood sugars will shoot up. And that's where you'll see patients, particularly when they're hospitalized and they're on the IV glucocorticoids, they're going to be on blood sugars, AC and HS, and they're likely going to be getting insulin coverage. Typically, it's going to be your rapid acting or your short acting, because we want something to, you know, cover their meal, because we generally do it before meals and before bed, okay? Once they're PO and they're tapering down on the PO, you're still going to see a slight elevation, but it's not going to be as high as when you do the IV steroids. Okay, let me work my way down here. These questions, good questions, good thinking, good clarification here. Okay, for someone with low O2, would you expect the answer to be sit the patient upright or administer oxygen first? Okay, for someone with an acute exacerbation, would you do the nebulizer, O2, or sit them up first? PrEP-U and ATI are different. Okay, very good question. So when you're looking at this, the idea of sitting the patient up first is going to help open up the airway. And if you go back to your basic principles of airway, breathing, and circulation, you do want to sit the patient up first, because if I can put all the oxygen on a patient that I want, if their airway isn't open, if there's some sort of obstruction or it's not fully open, that oxygen is really not going to be able to do the job that it needs to do. So when you're doing this, now this is assuming your assessment's done, but when you're doing this, you're going to sit that patient up first, get that oxygen on them, and then proceed with the breathing treatment. You know, it pretty much in that order. Now, the reality is when we're talking NCLEX, you're doing one thing at a time. So if I was on NCLEX doing one thing at a time, I'm going to sit my patient up first. I want to get that oxygen on them. Let's get that breathing treatment going. In real life, when you have a team, we're working together. You know, I'm sitting the patient up, already starting to get the oxygen. Hey, can somebody call respiratory therapy to give that treatment? Okay, but when you're talking about it from an NCLEX perspective, you're looking at one thing at a time. Priority points for azithromycin. So I had you do that med card on there, and that was mainly related to the interactive case study that was on Hinkle. So rather than getting tied up specifically with azithromycin, I want you to kind of think about your general principles of antimicrobial therapy. Okay, so azithromycin is an antibiotic, so it works specifically on bacteria. But you'll have things like Tamiflu, your Ostamavir, that is an antiviral, so that's going to work against the viral infections. Then you have things that are, you know, like, Lord, I can't even think, fluconazole is an antifungal. Okay, so regardless of what subtype of antimicrobial you're using, it's still an antimicrobial. So you want to think about the principles of antimicrobials, making sure your patient is taking them as prescribed on time to keep that consistent blood level and finishing the entire prescription. Like, those are really the key pieces with that. The other thing is they're used to treat an infection. So just a basic principle, you want to make sure you get your culture specimens prior to starting the antibiotic, antiviral, antifungal, you know, whatever antimicrobial we're talking about, okay? And then other key points for those would just be to think about maintaining hydration, because we do want to protect the kidneys. Sometimes the antimicrobials can be a little harsh on that. Obviously, they can cause some GI upset, so generally we'll give them with food. There are some specific ones that we give on an empty stomach. But again, if we look at, you know, the patient's taking it on an empty stomach and going to puke it up versus they're taking it with food and it might take longer to absorb, which is the lesser of two evils there? Okay, so rather than get tied up very specifically on azithromycin, I want you to really think about the principles of antimicrobials, because regardless, when we talk about respiratory and oxygenation, a lot of times the underlying cause could potentially be an infection. So regardless of what specific antibiotic we're giving or what specific antiviral we're giving, we're following those same basic principles. So that's where I really kind of want you to focus on. All right, some administration tips for oxygen therapy in regards to which device to choose. There are a lot that overlap. Okay, so when you think about this in general, we always want to start low and go slow. So if your patient's having issues with oxygenation, typically the first thing we're going to do is start with the nasal cannula. And we're talking 1 to 2 liters. Let's see how they respond to that. Now, keep in mind that oxygen therapy is going to be most effective if you have the patient appropriately positioned. It's also going to be helpful if they have a clear airway. So, you know, I can put oxygen on somebody, but if they have copious secretions and they aren't able to clear them, we need to suction them to help open up that airway so that oxygen can get down there and do what it needs to do. So typically, we're going to be starting with nasal cannula. That's really what we want. We kind of work our way up. So 1 to 2 liters, we can bump up to 4. Once you get to 4, you absolutely have to add humidification to it. Generally with a nasal cannula, and this is with a standard nasal cannula. They do have some that are like high flow nasal cannulas that are a little bit different. But with a standard nasal cannula, if you're getting to 6 and that's not doing the job, at this point, we now need to kind of switch over. And it depends on the status of your patient. If I'm talking a COPD patient, I really don't want to get above 4 liters. Really 1 to 2 is our ideal thing. If they're requiring more than that, then it's time to get them switched to a Venturi mask, just because that one is so specific in the way that you dial it that you can control the amount of oxygen that they're getting. So typically when we're looking at this from a respiratory standpoint, unless they are in absolute distress, like literally we're getting to the point where we're providing oxygenation, and if they get any worse, we're looking at BiPAP and intubation and ventilation. Then that kind of last resort is to put them on that non-rebreather. But again, your COPD patient, that can be more harmful than helpful. But for the most part, to answer your question, we're looking at nasal cannula. Simple mask is kind of the equivalent to nasal cannula, but used for a mouth breather. If they're breathing through their mouth, they're really not getting a whole lot of benefit from the nasal cannula. That's when a simple mask might be appropriate for that. But generally, we're going from the nasal cannula, Venturi mask, and then moving up to non-rebreather if that's where we absolutely need to go. So good questions. Can you go over PFT spirometry? Sure, but so basically both of those are looking at lung capacity. From a nursing perspective, we're not really seeing that a whole lot in the hospital if we're talking to the patient that we're dealing with as an acute exacerbation. PFTs and spirometry for true diagnosis and disease tracking should be done when they are relatively stable. You would not want to do PFTs while the patient's having an acute exacerbation. So that being said, just having an understanding that they measure, you know, a person's lung capacity, how much they are able to do, and that for COPD, your PFTs are your gold standard for diagnosis, and they're very helpful in tracking the progression of COPD. Okay, and those are a little bit different than like with asthma, where you have like the peak flow monitoring. The peak flow monitoring is a specific device that they breathe out in. It's very portable. They take it with them. So for asthmatics, they should be doing peak flow every single day to basically evaluate where they're at in their asthma action plan. Are they in the green zone, the yellow zone, or the red zone? And then, you know, respond accordingly. Can you please review cardiac output, preload, afterload patho? Sure. So cardiac output, just from a basic perspective, is all about how much blood the heart is able to pump with each contraction. And we talk about cardiac output, that is the blood that they're pumping out. And that's important because that blood is going to contain the oxygen that the cells need. It also contains, you know, your glucose that's needed to make ATP. So when you talk about cardiac output, conditions that will affect cardiac output are ultimately going to affect circulation to the tissues. So when we talk about preload is essentially the amount of volume that the ventricles are receiving. So when you talk about preload, if your patient is dehydrated, if they're fluid volume deficit, they're going to have a decreased preload. Maybe it's because they haven't been drinking a whole lot. It could be because of nausea, vomiting, diarrhea. It could be because of fluid shifting. So a patient that has a massive trauma or a patient that has burns, those fluids shift out of the blood vessels. So it's not that their entire body, like if I weighed them, they wouldn't necessarily have a weight change because the fluid is still there in the body. The problem is it's in the wrong compartment. Okay, so when we talk about preload, there's not enough fluid inside the vessels. So in that aspect, the ventricles are receiving less fluid. Well, if you give me less to work with, I'm going to be putting out less. Okay, that's just kind of how it is. So preload. Afterload refers to the pressure that the ventricle, and generally we talk about the left ventricle, but it's the pressure that the ventricles have to push against to circulate the blood. So if you have somebody who has, let's say just vascular disease, so they have some plaque buildup in there, so they have narrowing of the vessels. Well, if you kind of think about when you were a kid and you were playing with the hose and you were kind of ready to squirt your brother, you're holding the hose, just holding it, and the water's just coming out normally. But if you start putting a little bit of pressure on part of that hose, it increases the pressure inside the hose and you start getting a little bit more pressurized water coming out the end. All right, so the same thing really happens with the body as well. If you have problems circulation-wise, you know, narrowing of the arteries, plaque buildup, any type of blockage like that, that increases the pressure inside those arteries. So the ventricles have to push harder, push against that higher pressure, that higher afterload to be able to circulate the blood. Okay, so you have a couple things with that in relation to hypertension. A lot of times hypertension does go along with vascular disease. So you have the buildup of the plaque, but with the hypertension, remember you also have the angiotensin II, which causes that vasoconstriction. Again, the tighter the vessel, the higher the pressure is going to be. So when somebody has hypertension, that long term, if we're not addressing the hypertension and controlling the blood pressure, will lead to heart failure because of that long-term pressure that the ventricle was having to pump against to circulate the blood. So when you think about that, you have that aspect of it. With your hypertension as well, remember you have the aldosterone. So these patients also tend to hold on to water and sodium. So that actually increases their preload. You know, before we were talking about preload and somebody who has a low preload because they're dehydrated. Well, somebody with hypertension is likely going to have a normal or a high preload just because of that excess fluid. If they're receiving more into the blood, that just, or into the ventricles, that means that's more that the ventricles have to pump, they have to work harder. So when you think about it from that perspective, it's really important to consider the different classifications of drugs that treat heart failure. You'll have things like diuretics. Well, those diuretics, okay, particularly your thiazide and your loop diuretics, they're aimed at decreasing the preload. They do some other stuff too, but they're aimed at decreasing the preload. Okay. Now, the aldosterone blocker, which is your spironolactone, and that one is also considered a potassium sparing diuretic. So that one is going to also try to decrease the preload, but in that aspect, it's working on the kidneys, and it's also telling the body to not hold on to that sodium and water. Okay. If I have my ACE inhibitors or my angiotensin II receptor blockers, those are trying to affect afterload by trying to open up or dilate those blood vessels. Okay, so if you kind of have an idea of how things work, just that basic preload and afterload concept, it sort of makes sense the meds that they're on and how those are going to help that patient. Okay, say a patient's blood pressure is 124/98. Okay, systolic and diastolic pressures fall into different classifications. Do you go with the classification of higher severity? Yes, you do, because both of them can cause a problem. Now, it is very important to understand that you cannot diagnose somebody with hypertension based on one reading. Okay, remember the diagnostic criteria. They have to have 2 separate readings on different occasions, different days, and they're supposed to be what we call professional readings. So it's not, I went to the Rite Aid to pick up some Advil and I sat there on their automated blood pressure cuff and it checked me out. When we talk about truly making that diagnosis, it's based on a professional reading. So you're, and really at that point, you're talking the provider or an RN. I understand when you go to the clinics, you're going to have your MAs, your LPNs take those readings as well. If we're talking a new diagnosis of hypertension, those are going to be repeated by the provider to really get that true, accurate provider number. And you need to have 2 abnormals on 2 different days by that, solid provider for you to truly make that diagnosis. But yes, when you have one like that, you're going to go with whichever one is higher, whichever one fits that criteria. Because if I'm just looking at the systolic, I can miss some very serious issues. Because if you think about the systolic, that is the pressure during systole when the ventricles are contracting. Your diastolic pressure is the pressure when those ventricles are relaxed. And if that is high as well, that can affect blood flow return to the heart. It can also, again, affect the pressure. It's the pressure that the ventricles are then going to pump against. So that is very important. You always go with the classification of higher severity. Okay, great question. Right versus left side of heart failure. I'll go over it briefly. I'm not going to get too into depth because you don't necessarily need to be too into depth for today. But essentially, when you have somebody who has hypertension, we worry about them long-term developing heart failure. So let's just start with the left ventricle first, or the left-sided heart failure. So the left ventricle, when it is pumping the blood, it's pumping it out to the periphery of the body. So it's pumping against the pressure of all the external vessels. So over time, if that pressure is high and that ventricle is having to pump against that pressure, that ventricle will have to work harder, so it will become enlarged. And when it becomes enlarged, it's, you think, oh, it's larger, it's going to pump okay. No, it's actually less effective when it becomes enlarged. And if your left ventricle eventually cannot pump effectively, you will have fluid back up into the left atrium. back into the lungs. And that's where you get your pulmonary edema, you get your crackles, your acute shortness of breath, hypoxia with your left-sided heart failure. Okay. So switching to the right side, if we think about the right ventricle, it's pumping against pressure. The pressure generally isn't as high because the right ventricle is pumping to the lungs. Now, if you have somebody that has a pulmonary embolism, or they have what we call pulmonary hypertension, where their pressures are higher in the lungs, and you can see that develop with your COPD, particularly end-stage COPD. If the pressures are increased in the lungs, then the right ventricle has to pump harder to overcome that pressure to push that blood into the lungs where it can get oxygenated. Okay. We also call that cor pulmonale, that right-sided heart failure. Okay, so eventually the same thing is going to happen. If that right ventricle has to keep pushing against that high pressure over a long period of time, you're going to get this right ventricular failure. So when the right ventricle cannot pump effectively, now you're going to start seeing blood back up from the right ventricle into the right atrium and then back to the periphery of the body. So with right-sided heart failure, you're going to see things like edema, particularly in the dependent areas, the legs, or if your patient's laying, is going to be dependent edema. You'll see that jugular venous distension, okay, that JVD. That's what you're going to see more if it's just right-sided heart failure. Now, the reality is, if you have somebody with left-sided heart failure, eventually it is going to progress into essentially dual heart failure, where they have both. So you can have somebody that has both, that's presenting with an acute exacerbation of heart failure, that is showing both, but you're going to see the difference with the symptoms. So when somebody comes in with an exacerbation of their heart failure, and they have those pulmonary symptoms where they are short of breath, they have crackles, they're filling up with fluid, we typically treat that as left-sided heart failure. Because when you think about what's going to kill them first, it's going to be that lack of oxygenation from that left side back into the lungs. So hopefully that makes sense for whoever asked that. Other questions? I've kind of gone through, I think I've hit everything in the Zoom group chat. So great opportunity to ask questions if you have more. Again, I'll reiterate, if anybody's typing in questions, I'll reiterate in the meantime, if you have not looked at the Jeopardy game, if you have not looked at the pharmacology games in the Google Classroom, if you have not done the ATI custom practice exam, you need to do that prior to taking today's exam. They were created specifically to help you prepare for today. So make sure you are using those resources. Okay, great. Another question, can you go over left ventricular hypertrophy? So all that means is that you have enlargement of the left ventricle, which is kind of what we were talking about with left-sided heart failure. So that hypertrophy, that enlargement occurs because the muscle is having to work harder in order to pump that blood. So that's where you get the enlargement. Are you able to open the ATI test up again so we can take it a second time? Yes, I can do that. I had put a 24-hour lockout in between attempts. So some of you have already been able to take it twice, depending on when you took it the first time. But I can go in there as soon as we're done and I can remove that lockout time so you are able to access that again. I will do that. Other questions at all? No, no questions? Really? Really? Okay, now, last minute tips. When you're looking at this, remember what we talked about. These are oxygenation problems, perfusion problems. So these concepts are not just solely to asthma, to COPD, to pulmonary embolism. Really look at your things globally. Airway clearance is airway clearance, regardless of whether we're talking about somebody with pneumonia that has copious secretions or somebody with cystic fibrosis who has copious secretions, okay? Secretions are secretions, regardless of the cause. The goal is to open up that airway, okay? Again, oxygenation is oxygenation. Regardless of what the underlying cause is, I'm going to use my oxygen therapy to support that. Now, obviously with any type of care plan, with any type of illness, you always need to have an intervention that treats the underlying cause. So when you think about the differences between these things, and I'm going to pull in the 2 VSIMs you did not last week, but the week before. There was a VSIM for asthma, that was Jennifer Hoffman, okay? And there was a VSIM for pneumonia, it was Mona Hernandez. They both had oxygenation issues, okay? If you did their assessment, they both had abnormal lung sounds, they both had issues with their O2 sat, and they were telling you they couldn't breathe, okay? Now, things that were similar between those, we positioned both of them upright so they could breathe better. Both of them received a nebulizer treatment to help open up the airway, okay? What was different about them? Jennifer's problem was asthma. So one of the other things that you did was administer IV methylprednisolone. We did that to help start reducing the edema in the airway, the swelling from the asthma exacerbation. So that's how we were treating the cause of the problem, okay? From Mona's perspective, her issue was being caused by pneumonia. So what did we do to try to treat the cause of that? She was getting an IV antibiotic, okay? So there will be some slight differences, but those differences are generally related to how we treat the underlying cause, okay? But the basic principles of oxygenation, your basic foundational interventions are going to be the same, regardless of what diagnosis you're talking about, okay? Will we need to identify any breath sounds or heart sounds? No, not by sound. You would not need to do that, but there may be some wording in a question that talks about different heart sounds or different lung sounds that you would need to know that information to kind of guide you in answering that question. Okay, in regards to the NCLEX style question on Friday where the corticosteroid was not the correct answer to open up the airway, I'm still not understanding why that wasn't correct. Okay, so that particular question was focused on airway clearance, okay? It was focused on airway clearance. And that question was talking about the problem with airway clearance was the secretions. Okay, it was the secretion management. So when they were looking at interventions to manage the airway, they're looking for things that are going to facilitate getting rid of those secretions. So I don't have it in front of me, but if I'm remembering correctly, one of the options was the postural drainage, the chest physiotherapy. So that's going to loosen those secretions, get them moving out the airway so the patient can expectorate them. I think the one was the controlled coughing, that you want to encourage the patient to cough to get that up. I forget what the other one was. The rationale that that particular source gave for that question was that the corticosteroid will help open up the airway, but it does that by reducing the edema in the actual bronchial lining. And that does not happen as quickly as your short-acting bronchodilator, or if I was suctioning the patient or doing the chest physiotherapy. So from a long-term perspective, that steroid will help open up the airway. And it is true that with an open airway, you can cough secretions up easier. I believe the source that had that question was looking for intervention specifically to promote airway clearance, okay? So like I said, that wouldn't necessarily have been the question that I would have used, or I might have used the question that would have necessarily been the distractor that I would have used, just because of how close that is. But always pay attention to what the question is asking. You know, if we're, I think there was a similar style question on the Unit 3 exam when we were talking about DVT. I think it was a select all that apply. But it was about interventions to prevent DVT after orthopedic surgery. And there were some things on there that were related to preventing atelectasis, which were things that we would do for the patient, but did not specifically relate to DVT. So I think that's the perspective that it was coming from. So just make sure when you're looking at the question, what is the question asking? And don't overthink it. You guys have been doing this content since foundations. You really have. And that's why part of the thing when we were starting this unit, I said, back, when we started, to go back and look at that foundational content, because it helps reinforce that. The incentive spirometry, taking those deep breaths in to help open up the alveoli. That's going to help prevent pooling of secretions in the alveoli, which can then affect gas exchange. So whether you're doing incentive spirometry, you're doing the actual just coaching the patient to do deep breathing and coughing, all of those are aimed at promoting oxygenation. Okay, can you talk about target SpO2 percentages for COPD patients? Sure. So our COPD patients, we really like to keep them probably between about 88 and 91%. 92, okay, we start getting above 92, we get concerned about oxygen toxicity. Remember, your COPD patients, their drive to breathe is not based on low oxygen, it's based on high CO2. So as you add more oxygen to them, yes, you're increasing their oxygen level. By doing that, you're pushing down their CO2 level, which in a normal person, that would be a good thing. But in your COPD patient, that can actually depress their drive to breathe. And that's actually what happened with Mr. Gomez in your ATI real life COPD scenario. He was on the 5 liters nasal cannula with the humidification. And, you'll notice from the ER report, he was alert and oriented. His SAT was 91%. He was doing okay. Well, when Nurse Allison saw him, his SAT was 93%. He's still on the 5 liters nasal cannula with humidification, but he certainly was not alert and oriented. He knew who he was. He knew he was in the hospital, but didn't know the hospital, didn't know the day's date. And if you notice, he was very slow to respond when she was verbally talking to him. It wasn't really able to follow directions, follow commands. So there was definitely that change in orientation and mental status there. And that was specifically related to that oxygen toxicity. And when you looked at his SAT there, he was up to 93%. Had that not been picked up and he would have stayed at that 5 liters nasal cannula, or, even if they had changed the oxygen and put it up higher, his O2 SAT would have went up, but for a little bit, but eventually he's going to lose that drive to breathe and he's going to crash on you. Surprised by the supplement questions on ATI practice test. No, what I did, I created that ATI custom practice test specifically for you guys, because one of the feedback pieces I got from students is that they wanted more NCLEX style questions. And while PrepU is good in the sense that it gives content review, they are not all written as NCLEX style questions. So you want to make sure you go in there and practice that, because those are truly written as NCLEX style questions. So that's why I created that custom practice exam, just to give you more practice with NCLEX style questions. The concepts are still the same, the oxygenation pieces, but that's more your NCLEX style. So we didn't actually go over them. It's developed as a practice assessment, so you should be able to see rationale, because I do have rationale turned on, I believe. I will double check on that. Are we going to go over the test and anytime after? I'm going to do the same thing I did with Unit 4 and providing those topics to review. Unfortunately, at this point, there is no secure way to be able to go over the exam the way we did in class. I would love to be able to do that. As an associate degree team, we just simply don't have the capability to do that. So if there are questions where, when I look at the stats, a lot of people have missed them, I will address those concepts in a future Zoom session, kind of like I did with the delegation, and approaching the questions from a global perspective. Or like last time when I said you got down to those 2 answers. One, both of them you want to teach the patient. One, if you don't teach, was absolutely going to cause them harm, versus the other one that could potentially cause harm. If something's going to definitely cause harm, that's going to be your higher priority. Vitamin supplements with taking the warfarin on ATI. Oh, okay. That actually, I think, goes back to foundational content. I think you guys had a unit, or a very brief unit, on complementary and alternative therapies. And it kind of goes over that. So I threw that one on there kind of as a throwback to that. Right now, from a basic perspective, I just want you to understand that if your patient is on warfarin, a lot of your herbal supplements are going to affect coagulation. So the big concept, the underlying concept there is that's why when you're assessing your medication or assessing your patient and you're verifying their medication list, it is so critical to make sure you are including over-the-counter medications, you're including vitamins, supplements, anything like that, because you do see, particularly with patients that are on anticoagulants, there are a lot of herbal supplements that will affect coagulation. And we get really concerned when it makes the patient at much higher risk for bleeding, okay? Can you go over heat concepts for peripheral artery disease? Absolutely. So peripheral artery disease, when we talk about heat concepts, there is some evidence to suggest that if you use heat, like in the lower abdomen or in the groin area, it can help vasodilate and improve circulation to the distal extremities. So that is appropriate. Using heat on the actual lower extremities itself is an absolute no-no. You just do not want to do that. It can actually cause more harm for your patient. I don't remember having a unit on alternative herbal. It would have been, if Mrs. Brenchley used the same setup that I used previously, it would have been part of that hodgepodge unit 8, where you had the health teaching, the self-concept, the death and dying, the sexuality. It was that hodgepodge unit. There was a little piece in there on alternative therapies, but the best thing to kind of do to review that would actually be to look at your ATI fundamentals book. There should be a chapter in ATI Fundies about alternative therapies. I wouldn't be overly concerned right now about if you didn't go over the herbal supplements and fundies. It's something that you can look at over the summer and moving forward. I would not be concerned at this point. I threw it on there mainly because it tied into warfarin, but I wouldn't necessarily fret about that at this point. I would at some point prior to graduation. There's the chapter in ATI that goes into alternative therapies. And I think there may be, that's ATI fundamentals. And I think there's also a chapter in ATI fundamentals, not in the fundamentals, ATI Pharm, that relates to some very common alternative herbal substances. That's kind of where I would focus moving forward. For the purposes of this exam today, we're not going there. Do understand that a lot of them do affect coagulation. That's probably the biggest safety piece when it comes to herbals, is looking at understanding that those things are going to affect coagulation, and they affect coagulation on somebody who's not taking warfarin. So I don't take warfarin. If I was using, some herbals, that can affect my coagulation, meaning I'm going to bleed longer if I would cut myself. That's a bigger concern for a patient already taking warfarin or already taking aspirin, because it already takes them a little bit longer to clot their blood. If I'm adding in this herbal thing, that's going to increase it even more. So that's where you get concerned about a safety piece. So from a teaching perspective, talking about, you're the nurse, you're taking care of a patient who is prescribed warfarin, or you're taking care of a patient who's taking aspirin therapy, or they're on some sort of anticoagulant therapy or something that's going to affect their clotting. One of the priority points for you is to look at that med list and understand, are they on anything else? You may need, you notify the provider, but you may need to provide that education to the patient that just in general, as a general concept, that some of your herbals can affect coagulation. And especially if you're already taking something that's going to make you take longer to clot, this can increase your risk for serious bleeding. Okay, so there's not specific herbal substances on the exam, but I want you to understand that concept. Okay, and that's the same concept if you had a patient who was taking warfarin and aspirin. Having those two things together is going to increase their risk of bleeding. Okay, so that's your piece as a nurse. What are you teaching your patient? What are you teaching them to report? If all of a sudden they're taking warfarin or not all of a sudden, they're taking warfarin and now all of a sudden they're seeing, wow, I have bruising all over my legs. That's a call to the provider to report that. Okay, heat therapy again. With the heat therapy for your peripheral arterial disease, there is some evidence that if you're using heat therapy on the lower abdomen or the groin area, that can help improve circulation to the distal extremities, but you should never be using heat on the toes, the ankles, the lower legs. Okay, great question. I was expecting that one to come. What do we do if our power or internet goes out from the incoming storms while we're taking the test? Obviously, I know the weather situation. First things first, if that happens, take a deep breath, you know, don't panic. If you're able to get in contact with me with the phone, you know, my phone number, I will make sure it's actually up on Plato. It was up on one of the previous PowerPoints. If there is a problem, and I'm not anticipating a huge amount of problems, but if there is a problem, just get in touch with me. I'm going to work with you. Okay, this isn't, you know, too bad, so sad. We're going to work with you. You know, we anticipate this is, nobody can control the weather. We can't control, you know, the virus and everything, but you know, we're going to work with this to make this as painless as possible. So if something happens with your power, first of all, take a deep breath. I don't want you going into a panic attack, but then just get in contact with me and we'll work it out. I don't want that to be a stressor on you. Okay. Because obviously I know with the gusty winds today, depending on where you live, that could become an issue. So know that I'll work with you, but let's not put the cart before the horse. Okay. If your power goes out, take that breath, get in contact with me, and we'll go from there. Okay. Any other last minute questions? I'm really pleased. 25 of you are on this review session. Like I said, it is being recorded. I am going to put it up on the class channel. Do make sure that you look at the Jeopardy game. You look at the farm games, you look at the ATI custom test. The discussion post, okay? That discussion post was part of online class worksheet 2. So if you did that worksheet and you posted your discussion, you got a response. If you didn't, well, then there's no response there. You also need to post a response in order to see other people's. So there is a response posted. You guys are put into groups. There's a response posted for every single group. So if you happen to put up a response, you'll be able to read the rest of those. It is not a separate graded assignment. It was actually part of the online class 2 worksheet. Okay. And it was related to a scenario of what patient do you see first. So the goal for that was for you guys to look at prioritization concepts. Okay. So make sure you look at those extra activities that we did, the Jeopardy game, the farm games, ATI custom practice exam. I will get on ATI right away and take off the lockout because there was a 24-hour lockout on that. So I will do that as soon as I'm off of here. So you're able to access that again. Like last time, right now, the testing window where you can access the test is from noon to 5. Once you get into the test, that's when your timer will actually start, and you have 70 minutes to take the actual exam, okay? But the window where you can access the exam, it is open until 5. That doesn't mean that it's going to cut you off at 5. So if I have somebody that gets on at 4:30, you're still going to have your 70 minutes for the exam. It's not going to cut you off at 5. But after 5 o'clock, you will not be able to access the exam. So just kind of keep that in mind. And again, if something comes up with the power and that, you know, take a breath, get in contact with me. Okay. All right. Anything else for the good of the order? Going once. Going twice. Okay, sold. You got this. You know this stuff. I always say a prayer for you guys every day. But you know what? You know this. Your VSIMs, your alternate clinical assignments, they help support this unit. Okay? You know more than you think you do. Think about it as an oxygenation question. Okay? Think about those global concepts, airway clearance, promoting venous circulation. You guys know this. You know it. So let the anxiety help you versus hinder you. So walk the dog. Okay? All right. I'm going to